Hi, my name is Scott Simon. I'm a neurosurgeon and spine surgeon at Orthopedic and Neurosurgery Specialist, and I'm here to talk about the surgical treatment of sacroiliitis. And there's certainly some controversy regarding the surgical treatment of sacroiliitis, but even the most skeptical of us can basically concede that there are a subset of patients who do have significant pain coming from their SI joint. And these patients do respond, albeit briefly, to repeated SI joint injections, and it would be nice to have a more durable solution for these patients. I have no disclosures. So the sacroiliac joint is a synovial joint, the largest in the body, that allows for the transfer of loads from the spine to the legs. And there's a large investment of fibrous tissue around the SI joint, muscles and tendons, which really immobilize the SI joint for the most part and really allow for very little movement. And so this SI joint moves maybe 4 degrees in early life and often gets more stiff as we get older and the fibrosis occurs across the joint. There's also something called Hilton's law, which is basically that any nerve that crosses the joint innervates that joint. And so you can see how complex the innervation of the SI joint is in this picture. And the presentation of sacroiliitis or pain from the SI joint is equally as complex. So there's been several studies looking at what causes low back pain. And in these studies, it is shown that anywhere from 15 to 30% of cases are due to pain coming from directly from the SI joint. And it's very well understood that sacroiliitis is a hallmark presenting symptom in something called a spondyloarthropathy or arthritis of the spine, such as in cases such as ankylosing spondylitis. But we also see SI joint pain in patients who've had traumatic injuries or have repetitive stress injuries with hypermobility syndrome, such as pregnancy, such that it occurs in pregnancy, or with Ehlers-Danlos syndrome, after infections, or after or due to biomechanical irregularities, such as significant leg length discrepancies, or with transitional lumbar vertebra. We especially see the development of SI joint pain in patients who've had lumbar fusions, especially fusions that are multiple levels and extend down to the S1 vertebra. And the presentation, as I mentioned, is very, very variable. And it's very difficult because these patients often are radiographically silent in terms of their SI joint. They can present with pain over the SI joint, but also pain in their buttock, leg, with even leg numbness and pain that extends to the groin. And often these patients are favoring that SI joint. They're not sitting on it, so they're sitting away from the pain, and getting up from sitting or climbing stairs causes quite a bit of pain. And so you can see there's a lot of overlap with other pathologies that occur in the spine and pelvis. But a fairly consistent finding is that when asked, these patients localize their pain right over their SI joint. So they point with their finger right over where the SI joint hurts, and they're almost always markedly tender in this spot. There are some provocative signs and provocative tests that can reproduce this SI joint pain. And when you get at least 3 or more of these tests positive and reproducing the typical pain, then your suspicion is increased that this patient is suffering from sacroiliitis. But really, the diagnosis of sacroiliitis is a diagnosis of exclusion. You need to exclude other causes of pain in the back, buttock, and leg, and groin, such as hip pathology, facet or disc pathology, lumbosacral radiculopathies from, let's say, a herniated disc, or even a spinal tumor that's seen on this CAT scan to the right that shows a prostate metastasis, and also superior cluneal nerve impingement. So our protocol is really laid out that we can diagnose sacroiliitis when you have persistent pain for 6 months, unilateral, with unilateral tenderness over the SI joint, and at least 3 or more provocative tests that reproduce this typical pain. There really can't be any contributing or confounding factors such as fibromyalgia, and there needs to be imaging that excludes any pathology in the spine and pelvis. Steroid injections should often ameliorate the pain, albeit briefly, and you need to have at least 2 SI joint blocks, injections of local anesthetic that completely, or at least 75% of the time, you get a 75% reduction in the SI joint pain on 2 separate occasions. And it's really important that these blocks be done intra-articular. You need to have an arthrogram of the SI joint when you do these blocks to make sure you're not just numbing the surrounding tissues. You need to make sure you're actually addressing the SI joint itself to say it's a positive response. So there are non-surgical treatments of sacroiliitis, such as pain medications such as nonsteroidals or oral steroids. There's physical therapy, chiropractic therapy, yoga, massage, acupuncture. There's an SI joint belt, which people can wear when they're up and about. And obviously, as mentioned, SI joint injections, either with steroid, local anesthetics. People are using stem cells or in PRP, and that's being investigated further. But for those patients who have consistent response, albeit brief, from SI joint injections, and the pain just does not go away, there is the option of SI joint fusion. And this fusion seeks to stabilize the SI joint, stop the pain, and stop that degeneration and inflammation that is occurring within the joint. And fusions of the SI joint used to be somewhat prohibitive because of that open extensile approach needed to address the SI joint and the high morbidity and poor outcomes from an open fusion. But recently, minimally invasive SI joint fusions have become much more available and allow for a much quicker recovery, a much less disruptive surgery, and with good outcomes. And these fusions can be done often through a lateral approach, often percutaneously, as seen in this picture, or through a posterior approach where you're crossing the joint with implants and bone to fixate and fuse across that joint. And here, I like the Silex system. It's what I use the most. This is by Globus Medical, where we use HA-coated slotted screws filled with bone graft placed across the joint through a lateral approach under biplanar fluoroscopy. And you can see that we get good fixation across the SI joint, and it allows for a good bony integration into the screw as well as bony fusion across the screw through the SI joint. And recently we've moved from the older Silex system to the new Silex Select system, and this allows for better integration on the sacral side of the screw, as well as more slots for bony integration across the SI joint, and allows for not only a lateral approach, but also posterior approaches as well. And the outcomes from SI joint minimally invasive fusion are fairly good. If you look across the board, there's certainly an improvement in patient satisfaction and decrease in patient pain scores, regardless of the system used compared with non-operative treatment. And we've also identified subgroups that actually do better and some that don't do better. So patients who do better are patients over the age of 45, patients with a longer duration of SI joint pain, over 3 years, but patients who are smokers, patients who use opiates over a chronic period of time don't do as well as patients who are not smokers and don't use opiates. And that, like any surgery, there's no risk-free SI joint fusion. All surgery has risks, and SI joint fusion is no exception. There's certainly later complications such as hardware failure or pseudoarthrosis where the bone doesn't integrate across the SI joint with a recreation or a reoccurrence of the pain the patient was experiencing, potentially necessitating a reoperation. There's also infection that can occur within the first several weeks after surgery. But the most dreaded complication, I think, is malposition of the implant with nerve injury or compression. And that's seen in this CAT scan to the right, where you have an implant that's too long, extending into the S1 foramen, injuring the S1 nerve root. And this results in an unhappy patient in the recovery room that needs to be promptly taken back for revision to relieve that compression. Now, we can try to ameliorate these occurrences with malpositioned implants with the use of biplanar fluoroscopy or neuromonitoring, but what we've really done is really shifted our whole practice to doing this surgery with computerized navigation and robotic guidance. And so here at Greenwich Hospital, we use the Globus Medical Excelsius GPS robotic system. We get a preoperative a CAT scan of the patient's pelvis, and we load that into the robot, and we actually plan the surgery entirely before we even touch the patient on the robot. And so then when we place our reference frame onto the contralateral pelvis, we're able to register the preoperative CT to an intraoperative fluoroscopic image, and then we bring the robot in, and we're able to basically do the whole surgery with real navigation. So you can see here, I'm able to plan out the incision with the robot using the computerized navigation, and the incision's only around 2 centimeters in length. And so we're able to really minimize the tissue disruption. And you can see on the right, I'm placing the screw across the SI joint under computer guidance, and you can see in real time the screw passing through the ilium into the sacrum across the SI joint, and it really allows for better accuracy, a longer and bigger implant, and better outcomes. We're also able to not only address the stability of the SI joint with the instrumentation, we're actually now able to fuse across the SI joint in addition to our implants. So we're able to actually plan trajectories of decortication across the SI joint with the robot, decorticate minimally invasively with custom instruments that we have developed here, and deliver bone graft either posteriorly or laterally into the SI joint for additional fusion that supplements the fixation and the fusion that occurs across the screw. So in summary, minimally invasive sacroiliac joint fusion does provide clinically significant improvements in pain scores and disability in most patients across multiple studies and implant manufacturers. But certainly more studies are needed to better identify who'd better benefit from SI joint fusion surgery and which approach and system provides the best benefit. Thank you very much.